Just tension pneumo and then tell me what you see clinically. Don't worry about it. I don't spell right most of the time anyway. So give me what you'd see clinically.
Silent on
Whatever side's affected, okay.
whatever side. That's my big one. Giving me the traumatic injury.
All right, so you expect some kind of trauma.
Late sign, or depending on how bad it is. Respiration.
Okay, Andy, come up here and add to it and tell me what Beck's triad is. Is he missing anything? Need anything? Because actually the findings that he's describing you're going to find in Beck's triad, so. It's on the other side. Yeah. Okay. Yeah, you can. Depends on whether or not you have a flail. What's the treatment for it?
Needle deposition.
Okay, where's it go?
Second intercostal space, mid-flicker, just above the third rib.
All right. Okay, you can go ahead and sit down. So here's a case for you. It's not one we're going to test on. It's just informational for you because this was something that was not appreciated by EMS on this unfortunate old lady. A 90-year-old woman who was awake and alert, lived by herself, had fallen 3 days previously, gone to the hospital, bruised her chest wall. They x-rayed her, it was all negative. The morning of the visit, she had fallen again and called EMS again and came in. She was tachypnic, breathless, and now she's a little old lady, 90 years old. So how big do you think a 90-year-old woman is? I mean, think about it. They're skinny, they're tiny. You should be able to see everything on her, right? She wasn't exposed to look at her chest. Her respiratory rate wasn't noted. Now, she was not brought in by the county EMS. She was brought in by this little retirement community's volunteer EMS squad. Okay, so they were all EMTs. Should an EMT be able to recognize the tension pneumo? Guys, EMTs here, right? Don't you think you should be able to recognize a tension? I mean, yeah, okay, the physiology of it is something you probably didn't get, but clinically, you should be able to tell a tension pneumo. So they bring her to the ER, and the lady is awake and alert and says, I don't want any treatment. She gets examined, and the provider examining her says, Mrs. So-and-so, you need a chest x-ray. I'm afraid you collapsed the lung. I do not want a chest x-ray. I want to go back to my home. Make a long story short, we convinced her that she needed to at least let us do something because clinically she collapsed the lung. Now, she doesn't put together the fact that her respiratory rate is high because one of her lungs has collapsed. To her, that means nothing. She says, I'm 90 years old, I'm ready to die. And I said to her, that's fine, but what you have can easily be treated. I said, and I would recommend we treat it. I said, I can put a little tiny tube in, we can evacuate the pneumo, and you'll be home in 2 days. Eventually, she consented to the treatment. I put her to sleep because I don't normally do that, but she's an old lady who is somewhat difficult to deal with, and it's just easier to put her down, put a tube in her. She had an almost 100% pneumo on the left, had shifted her heart and lungs over to the right. She had neck vein distension. She had a respiratory rate of about 30. Her O2 sats were in the mid-80s. Now, do you intubate a patient with a tension pneumo before you decompress the pneumo? No. Okay, that's a basic fundamental rule. You cannot tube a patient. What happens if you tube them and now you have a closed space? Okay, because they're connected to a ventilator or a bag. You have a closed space with that endotracheal tube in there. What happens to that lung and that pneumo? Yeah, you'll kill them. You'll kill them. That's what will happen. No, it re-expands. It depends on the size. Tension pneumos, you got to decompress them. And then we have...
But so emergency treatment is decompressing,
Right. Long term, they put a chest tube in. Some do. Pneumos less than 20% are not decompressed, and then they don't put chest tubes in them. They get reabsorbed over time, and the patient's fine. Just have to do serial x-rays on them. This lady, though, had 90% pneumothorax on the left, so she needed a tube. I put a little one in her because she was hemming and hawing about having anything else put in there. And the smaller ones take a little longer, just like a needle sometimes. It takes a little longer to decompress the lung. So they get admitted, they get a whole Pleurovac set up, and you know, her vital signs improved. Her blood pressure was 220 over 110, came right down once we started decompressing her. Pulse rate slowed back down. Her SATs went up. Because even on O2 with a big tension like that, she's not going to be perfusing well. Because one whole side of her chest has nothing but air in the space, and even though blood might be flowing to that lung to some extent, it's not being oxygenated. So you have a big shunt going on. It's called a shunt when the blood is shifted like that, and it's not being perfused. So in her case, she did fine, went home a few days later. But just so you understand the difference with tensions, and you have to do something for them. And in traumatic patients, you have to give that consideration, because if you don't, the patient will die. And that's a preventable death. Okay. You guys want to take a few minutes to go do whatever you need to do, and then we'll start again at 10 with a presentation. So you can take your break. And when you're done with your books, give them to Greg in the next week or two, okay? Make sure your name goes in them. Oh, no, I'm working anyway. I gotta go up, all the way up to Tampa tonight to work at 7 o'clock, so. Yeah, I'll miss the game.
Well, you don't have to see the game to win money.
I am not lucky like that. God doesn't bless me that way. He blesses me by giving me jobs. That's how he blesses me.
I'm lucky. I've been doing this for 18 years here, and I won last year for the first time.
Oh,
So
yeah.
maybe I'm way behind.
Yeah, I don't, I never win. I can go to Vegas.
When you watch the game, though,
Yeah, I'm sure.
for a whole different kind of thing.
I'm sure.
How long did you say? We got, how long?
Till 10.
5 minutes?
No, till 10. That should be enough time to do what you need to do. My watch says 5 of now.
You asked who about that, Frank?
You said there's two of them at the same time.
On your office? In the cabinet, they've been swapped out already. I'll look again when I go, but.
Yes, Charlie. Just give it to Randy when it comes in.
Hey, Doc, on the two cases, am I right if we go ahead and put our pattern of thinking of what we're thinking about?
Yeah, that's what I want to see. On case 1, you mean? Yeah, that's the only one we're doing. We're not doing any other cases, just that first case, the one that we presented on the PowerPoint. So write down what you're thinking about and the reasons for the decision you're going to make.
But obviously, if we're into this innovation, is all going to depend on the outcome of the operating, because if the pattern is in,
Well,
I got a lot of things that go through my mind.
Right, but think about, this is a real-life situation. These aren't made-up cases. So think about, if you respond to a scene and had that patient with those parameters, how would you treat that? You don't need to know anything else. Just with there's certain basic stuff you're going to do for every trauma patient, and you still have to write them down. You know, the information I gave you was to determine what you need to do with that patient, because the treatment that was rendered was inappropriate. Okay, so yes, you're going to be doing your basic immobilization anyway. They're all going to get a collar because the guy's unconscious, and there was a bad MVA. The problem was that they didn't assess him. They did the rote bullshit that they do, but nobody thought about anything that was going on. They didn't look at what they were doing. Well, understand he's only 45, and as far as you know, what you're seeing is purely trauma. Okay? We don't know of any medical issues because the guy can't tell you, he's unconscious. So you're seeing a traumatic event, and how do you manage that is what we're dealing with. How do you manage that trauma? To make it easier, he doesn't have any medical problems.
I was putting that in as part of my differential in case of blood sugar.
But see, that's a standard that you're going to evaluate. So you're going to treat this like you do every trauma patient that you see who presents this way. You don't need any other information. You're going to do the basic stuff you do for every trauma patient. And all I'm saying to you is that the basic stuff you normally would do for a trauma patient wasn't done for this one and resulted in his death. Okay, you guys ready? So we're going to look at some anatomy and physiology. Nothing too confusing or in-depth right now, just to review. Remember, physiology is really how the body works. That's the most important part of what we learn. So these have the 10 pages of learning objectives, which is fine. You already know this. I'm not going to sit here and go through each one of these. Yeah. Okay. So, anatomy is important. You all understand that. That's a basic concept. But what I'm saying to you is that as important as anatomy is, physiology is more important because it has a little more bearing on what we do and the disease processes we look at and in how we treat it. If you don't understand the physiology, you won't understand why certain things work and certain things don't work in the treatment. In order for you to be able to think outside of the box and think about what's going on with the patient, you got to understand the physiology. The fellow who had the cardiac arrest at the swimming pool, the only reason he survived was that Bonita's medics understood what they were looking at and looked at other causes for the guy's problem. Otherwise, he would have been pronounced by the medics from the county that were there, because their idea was there was nothing more they could do because they exhausted their protocols and they weren't allowed to do anything more. Now, I must have, I'm sure Greg has them too, at least a dozen emails from one of the lieutenants at EMS saying, well, great job, great save, but why did you do this, 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 this? So it makes me wonder, are they interested in following some bullshit guideline that's supposed to be a guideline, or are they concerned about saving lives? And my impression is they're more concerned about following the guideline.
What did they do that was outside I don't even know what
The call went out for this guy that collapsed in the swimming pool, yeah. They just had that Phoenix thing here, didn't they, last month or something?
Was it near drowning or?
No, he was swimming and got out of the pool and collapsed.
Oh.
EMS came, it was right across from one of the fire stations. They responded. There's a doctor there, an ER doctor. They worked the patient. EMS said, well, we went through our cardiac arrest protocol and there's nothing left to do. And our medics were assisting them, and they said, would you mind if we took over this case? They tubed the patient, and they started thinking about what was happening. Guy had a scar on his chest. He had a pacer in his chest. Okay? Now, they went through the cardiac arrest algorithm, which, is fairly basic. Does it say anywhere in there that that's all you're allowed to do? Does it not say that you can think of other causes, other things? So, they gave Narcan, which the lieutenant from EMS says, well, Narcan was an old treatment, not really indicated. It's more a medical legal thing in case the patient did narcotics, but really you're going to manage their airway with intubation. Oh my God, he actually agreed with the intubation? So therefore, it's not really indicated. Yeah, that's all well and good, but still narcotics cause other hemodynamic effects. So Narcan was a good idea. Second thing they gave, bicarb. They gave Narcan. Aramedics did, not EMS. Yeah, this is after they went through the algorithm 3 times, and they wanted to call it, and the ER doctor said, you're out of your mind. This guy looks young. He's like 70 years old, 65 or 70. You can't call this. And our medics then stepped in and said, do you mind if we take over from this point? I don't remember now. They may have given glucose. What was the last thing they gave?
They gave sodium bicarb, glucose, Narcan, mag sulfate.
Mag, that's it. Okay. Now realize that we don't carry some things, so we can't use them because we don't have them. But, so this is what they gave. The guy got a rhythm and a blood pressure back, took him to the hospital. 3 days later, or some time frame like that, he walks out of the hospital and you see him here. So he would have been a statistic if it was up to EMS. But let's think about this for a minute. So you see somebody that's collapsed and has a pacemaker defibrillator device, okay? What do you immediately know about that patient? What was that last one? I thought somebody said cardiac dysrhythmia. This is the key right here. All right. So they're looking at this and they're saying, well, if he's on a pacer defibrillator, then we know a couple of things without knowing this man at all. We know for sure that he has to be on antiarrhythmics, that he must have an underlying dysrhythmia, and he may be on anticoagulants. We can't do anything about the anticoagulants, okay? The dysrhythmia is supposed to be controlled by the pacer, but it's not. Something's wrong. Those cells are not firing. So that means he's on a dysrhythmic agent that is preventing those cells from getting that impulse and firing. And what happens with antiarrhythmics in high doses is that's what they do. They close down the channels. What channels? Those are the main ones. Now, do pacemakers normally, or I shouldn't say normally, are pacemakers used mostly for AFib? No. They're not. They're usually used for ventricular arrhythmias, for pauses, for VTAC, and that kind of thing. Would you expect to find calcium in a patient with a ventricular arrhythmia? Do they use calcium channel blockers for that? That's used mostly for AFib, atrial arrhythmias. What about sodium channel blockers? Give me some examples of sodium channel blockers. Just general classes. Okay, that has some effect. Seizure meds are a big one. Antidepressants. And of course, certain cardiac drugs. So looking at this guy, pacemaker, they don't see a rhythm, the pacer doesn't seem to be capturing. They determine that, well, what can we give this man that we carry in our box? Well, we don't have calcium. EMS in their infinite wisdom eliminated that. Do we have sodium? Well, wait a minute. We have some bicarb in there, that's sodium. So what did they do? They gave him bicarb. What was the result? He was on an antiarrhythmic called flecainide. What is flecainide? How does it work? Where does it work? It's a sodium channel blocker. That's how it works. So by giving him bicarb, they gave him sodium to try to offset the blockade that the flecainide induced. Now, was he toxic from flecainide? Who knows? And they don't measure it, so who knows? But the point being is that they thought about what they were looking at, they thought about what they had available, and they addressed the issues that they could do something about. Magnesium. Give me one drug that lowers magnesium. One drug. Probably one of the things that most people take. Lowers magnesium levels. Okay? So in this patient, understanding physiology, looking at what they see clinically, realizing that, okay, if he's got that thing in his chest, he's got to be on some antiarrhythmics. What can we treat? Well, we don't have calcium, so we ain't treating that. We got some bicarb. We can treat the sodium channels and make a difference maybe. You know, we're addressing the glucose, and EMS, the lieutenant from EMS said, well, I don't see why you gave him glucose. Didn't you check his sugar?
Yeah, and all the free time we had during the code. It's not gonna hurt.
Exactly. That's the whole point. It's not going to hurt him. Neither is Narcan. Neither is bicarb. Because you know what? If somebody's in cardiac arrest, are they not acidotic to begin with? Are you really going to hurt him giving him bicarb? Are you going to make him alkalotic? It would take a shitload of bicarb to do that. So the important thing to understand is they understood the physiology. They thought about what they were looking at. They assessed the situation clinically by what they saw, and they used what was available to them to make a difference and to keep somebody alive who would have otherwise been pronounced dead. So I think they did a great job. And anybody that criticizes them for using these drugs and for thinking this way is obviously a moron. No ifs, ands, or buts, they're a moron. Since when does following a protocol supersede saving somebody's life? Is that what this country and this agency has been reduced to? Okay, I'll get off my soapbox.
Hold on, stay on it 1 second. I do have something else.
Did he take Prozac?
Don't know.
No, the question is that since the email that Lieutenant